Welcome to Roadmap to Residency Evidence-Based Application. In this video, we will be discussing in brief about the cardiovascular pathology. Now, everything that we will be discussing in this video, all the questions, all the topics, we have different videos of these all topics in the cardiology modules. You can go and watch it where I have discussed the anatomy, pathology, pharmacology, physiology, and everything in detail. We have videos touching all of these topics, separate videos of all of these. So here we have the first question. So a 35-year-old man comes to the office with progressive fatigue, dyspnea on exertion, and lower extremity edema over the last 2 weeks. Preceding these symptoms, he had an episode of fever, runny nose, and myalgias that resolved after several days. The patient has no other medical history, takes no medication, and has no significant family history. He occasionally drinks alcohol and does not use tobacco. Blood pressure is 102/74 and pulse is 98. Physical examination reveals jugular venous distension, bibasal crackles and lung auscultation, and 2 plus pitting edema involving the lower extremities. Which of the following echocardiographic findings is most likely to be seen in this patient? Concentric left ventricular thickening and abnormal diastolic relaxation, dilated ventricles with abnormal systolic ventricular function, high systolic pressure gradient across the aortic valve, regional valve motion abnormality, systolic anterior motion of the mitral valve. So this patient's presentation with dyspnea, lower extremity edema, jugular venous distension, and pulmonary crackles is consistent with decompensated heart failure. In a young patient who develops heart failure following a symptomatic viral prodrome, dilated cardiomyopathy due to viral myocarditis should be suspected. A number of viruses have been implicated in causing DCM, including Coxsackie virus, adenovirus, and influenza virus. It is believed that an inadequate immune response to the viral infection allows virus to infect and persist inside the cardiomyocytes. Again, we have a two-part video of heart failure in our cardiology module. You can go and check that. So a 55-year-old man presents to his primary care physician for a routine checkup. He has a past medical history of type 2 diabetes mellitus and dyslipidemia. His blood pressure readings over the past several visits have consistently been elevated. On examination, his blood pressure is 160/95. He is overweight with a body mass index of 30. Lab investigation revealed elevated fasting blood glucose and lipid levels. Which of the following pathophysiologic mechanism is most likely contributing to the development of hypertension in this patient? Increased sympathetic nervous activity, impaired insulin sensitivity, activation of the renin-angiotensin-aldosterone system RAS, endothelial dysfunction, dysregulation of sodium and water balance. Now, the correct answer is C, activation of renin-angiotensin-aldosterone system. Hypertension is a multifactorial condition influenced by various pathophysiological mechanisms. In individuals with type 2 diabetes mellitus and dyslipidemia, several factors contribute to the development of hypertension. Activation of the RAS plays a significant role in the pathogenesis of hypertension by increasing the systemic vascular resistance and promoting sodium and water retention. Now again, we have a complete video of hypertension in our cardiology module. We can go and check that, which also talks about the RAS system. A 45-year-old woman presents to the cardiology clinic with complaints of fatigue, dyspnea on exhaustion, and orthopnea. She reports a history of rheumatic fever during childhood. On examination, a mild diastolic rumbling murmur is heard best at the apex along with an opening snap following S2. An echocardiogram reveals thickening and restricted motion of the mitral valve leaflets with evidence of left atrial enlargement. Which of the following pathophysiological process is primarily responsible for the development of the mitral stenosis in this patient? Myocardial infarction, calcification of the mitral valve, papillary muscle dysfunction, bacterial endocarditis, or autoimmune mediated inflammation. You can pause the video and think about the answer. So autoimmune mediated inflammation is the answer. Mitral stenosis is a valvular heart disease characterized by narrowing of the mitral valve orifice. The most common cause worldwide is rheumatic heart disease, which results from autoimmune mediated inflammation following an episode of rheumatic fever. We have explanation of rheumatic fever and valvular heart diseases in our module in our modules in cardiology. You can go and check that. Now we have one last question with us. So, which of the following histopathological changes is most likely to be observed in the myocardium of this patient following an acute myocardial infarction? Why I tell you to always read the last line first, because just we have read the last line and we don't even need to read the rest of the question vignette. We can directly jump into the options. So coagulative necrosis with preservation of tissue architecture, liquefactive necrosis with formation of a cystic cavity, caseous necrosis with granuloma formation, fibrinous necrosis with deposition of fibrin and inflammatory cells, fat necrosis with infiltration of adipocytes. So yeah, coagulative necrosis with preservation of tissue architecture. The most common form of necrosis observed in MI is coagulative necrosis, characterized by the preservation of tissue architecture. In the acute phase of MI, there is cessation of blood flow to a portion of the myocardium, leading to ischemia and subsequent cerebral injury. Coagulative necrosis occurs due to the protein denaturation, resulting in the loss of cellular structure while maintaining the overall architecture of the tissue. Very, very important concept. Histologically, coagulative necrosis in the myocardium following MI appears as a pale area with loss of striations and nuclear staining, surrounded by a hyperemic border known as the area of ischemic injury or infarct zone. Thank you for watching. Keep studying hard.